very, I can't think of what the word is, asymptomatic. It was all asymptomatic things. So it was by complete chance that I was, that I went in to do the trial. And then from the trial, then they were able to see that there's something growing in my head. There's a glioma, and then unfortunately, with COVID happening, I didn't get seen the second time in with Tim Jones very quick. But when they did, they were able to see that the tumor is growing at quite an alarming rate. So
and hence the surgery, and just to get to know you a little bit more, do you have any other medical problem apart from this brain tumor? I
have minor tear in my knee, in meniscus damage.
Meniscus. Any surgery before on your knee?
No, I was going to go in for surgery, but the doctors said it wasn't essential. And then because I was trying to join the army at the time, I said I won't take the surgery, seeing as how it's not essential.
So apart from codeine, do you take any other medication?
No.
Have you ever been on steroid like Dexa or prednisolone?
No steroids.
Okay. Any allergy to food or medication?
No.
And just to know a little bit more about your family, are you aware of anyone in your family who has cancer before?
Yeah, our granny died of pancreatic cancer, and I think that's it, isn't it?
Pascal, it's on my mum's side.
Your mum's side, just pancreatic.
Any of the wars? Francis died.
Francis, yeah.
Yeah, there's a few.
Your uncles or?
One great uncle, one granny, and one aunt.
Do you have any idea what type of tumor they got, if you know? Is it,
my granny was pancreatic cancer, I think.
But the others are, you're not sure?
Pascal was lungs. He smoked though.
Okay. Alright. And Ian, I know you work as a fitness instructor. And are you doing any other jobs apart from that? Because the gym is closed for the past few months.
No, all of my sources of income were to do with fitness in some regard. So I was a referee and taught fitness classes, and then taught fitness classes with another company. So they were all to do with that. That job is actually coming back slightly because it's all based in parks outside, so they're still able to teach it, but it's kind of limited.
Are you looking into going back to work soon, or?
As soon as possible, yeah. I'll try to get into it.
Okay, good. And
they were saying that Tim was explaining about the chemotherapy and the radiotherapy, that towards the end of it I'll be getting pretty tired, so that might make all of my jobs involve very high levels of activity. So like as a referee, I'm moving around all the time.
And do you interact with a lot of people, or?
How do you mean interact?
Like, do you interact with people coming into gym, and because we also need to look at the risk of getting any infection?
Yes, but there still is a level of distance that is more enforced, but it would be an increased risk of contracting COVID.
Okay. And do you live alone in London, or?
No. So one of my friends is also my housemate, and he currently lives with me. And there is a spare room in the house that we are trying to get someone else to move in with, because the whole house is rented by 3 people.
Okay.
And at the moment, because someone moved out during COVID, and it's difficult to try and get more people in, and with my surgery as well, it's been hard to try and get someone to move in. But now that I've passed by the surgery, we're trying to get someone back in.
You live in a flat or a house?
It's a house, but it's been turned into a flat. So like there's a staircase, and then it's flat from there.
Any problem with going up and downstairs after
No.
the surgery?
No.
Okay. And do you smoke?
No.
No. And do you drink?
Yeah, but I haven't been drinking a lot lately.
Okay, that's okay. And do you have a partner or?
Nope.
No. So, okay, thank you for all your information. That's really helpful. Have anyone discussed with you about the report from the surgery?
Tim did, yeah. He went over some things and basically just explained about the oncology, or not the oncology, the radiography and the chemotherapy, and how it's going to be happening like quite soon as the scar on the side of my head heals up.
Yes, it's healing quite good. But do you have any idea of what it is in the brain? Did he mention anything to you about glioma? Yeah,
he was saying about how it's the way he described it was like if you imagine cancer as a malignant cancer as a butterfly, the thing that I have in my head is a caterpillar, so that if left to do its own thing, it will transform into it, or that it will eventually transform into it no matter what, but that the chemotherapy and the radiography can stop it changing and growing and expanding.
Yeah, you're right somehow. So what we see in the brain is called a glioma, and that's one type of brain tumor. And for glioma, there are different grades. So there are low grade and high grade glioma. So as what it says in the name, low grade means something which is lower in the hierarchy, and it's unlikely it will progress really fast. But high grade, it sounds more malignant, and if we leave it there, it will definitely grow and turn into something worse in the future. And from the report that we have received, and in the report they also look at certain molecular in the tumor, just like a DNA in our body, and they found that it is a high-grade glioma. High-grade, there are two high-grade glioma, that's grade 3 or 4. But at the moment, we can't really tell you whether it's 3 or 4. What we know at this point is this is a high-grade glioma. It could be what we call an astrocytoma or glioblastoma. But anyway, because it's a high-grade glioma, after the surgery, what we normally recommend you to do is to get further treatment with radiotherapy and chemo to just reduce the risk of the tumor growing again, progressing, and also it will improve your life expectancy in the long run.
Do we know what the difference is between the 3 and the 4?
So that the names are different, and also the final outcomes as in the life expectancy after the treatment is slightly different as well for both grades. The difference is, I would say, is a few years in terms of the survival. But we can go into detail about that when we get the final report.
So is it when we find out whether it's a 3 or a 4?
So we can get the final report in about 2 weeks' time. Then we will be able to tell you. But in terms of the management for grade 3 and 4, it's almost similar. Both needs radiotherapy after the surgery, and also with chemotherapy as well. The slight difference is the schedule on the chemotherapy treatment, but we just need to get you into the radiotherapy first as soon as possible, and there's no much difference in between both of them.
What would be an estimate of the life expectancy of a grade 3 versus grade 4? Tim was saying that it was possible to be about 1 to 6 years.
So as I say, the difference in between grade 3 and 4 is quite big. So if it's a grade 4, the life expectancy will be about 1 to 2 years on average. So, but it depends on patient's age, your fitness level, and how was the surgery, and also it depends on
so all of those things will go in his favour.
Yes. If patients get a good resection after the surgery, like what you had, it's obviously a good factor when we look into the long-term survival rate, and your age as well. If you compare a 70 years old guy with you at 30s, so patient in younger age, usually they tends to do better. Yeah. So what I say, 1 to 2 years is an average on the population, all the patients with high grade, grade 4 glioma, but I would say there are patients who do better than the average. Obviously there are patients who do worse than the average, but probably to begin with they are not very fit and well, and if they have a lot of medical problem, that's another contributing factor as well. For grade 3, I think Tim say about 6 years. That's 5 to 6 years what we're looking at. But the recent trial on grade 3 is not matured yet. So the new treatment like a new sequence of treatment that we are doing right now. We haven't received a final data on the long-term survivors. Probably can go more than 6 years. Yeah, but there's a huge difference in between 3 and 4. But I don't think we need to worry about that now, because it just makes you feel more anxious. Because anyway, after the surgery, both grade 3 and 4, you will need radiotherapy treatment with chemo, and then you would need additional chemotherapy treatment after the radiotherapy. Yeah. And have you heard of radiotherapy treatment?
Yeah. Is the treatment done in here, or is it Tim was explaining to me about how the therapy is relatively simple, that it's literally just an X-ray goes through where the tumor is.
Yes.
And so could it be done in any of the hospitals near me, or is it always going to be the one down in Sutton?
So we need a machine. So the machine is in Sutton.
Oh, okay.
So you wouldn't get the expertise or the machine in any other local hospital.
So it's always going to be here.
Yeah, the nearest one for you is probably here.
All right. And is it done how many times a...
So you will need 33 treatment in total, 3. So the treatment will be on every Monday to Friday, once every day.
Yep.
So you get 5 treatments in a week.
Yeah, and then the weekend
it makes
off.
up total of about 6.5 weeks treatment. Because currently, when we're looking at the report, we think you are at grade 3. So grade 3, they normally receive 33 treatment, but for grade 4, what we normally do is 30 treatment. So, but for now, because we wanted to just put you into grade 3 first, so it's 33 treatment for now, but it might change later if we receive the final report which saying that it could be anything at another grade, then we might change the treatment to 30 fraction, but for now it's 33 fraction, which will take you about 6.5 weeks. So it's once daily treatment. Each treatment takes about 15 to 20 minutes,
Mm-hmm.
and it's outpatient treatment. You come for the treatment, and then you go home after that.
Yep.
Are you aware that you're not allowed to drive?
Yeah.
Yeah, so you can get hospital transport if you need to, but if you feel like you're fit enough to go into public transport, then it's up to you.
I think the hospital transport would be better, sure. Is that
Yeah.
like a taxi or?
It's like an ambulance, isn't it, Claire? But
And
you
they
might need to.
They'd pick him up from his house? And,
Yes.
Oh yeah.
I think just in terms of like if COVID wasn't happening, I wouldn't have a problem at all doing public transport.
Yeah.
But because of that and the fact that
Yeah, that's quite sensible.
my the radiography and the chemotherapy gets
Yes.
cancelled if I get COVID, so I think it's very important that I be as safe as possible with that.
That's sensible. You can request for hospital transport while you're receiving treatment, and yeah, so it's
Like I can't imagine that I would need an ambulance for any reason, but just if there's something simpler that you guys
yeah. I think
have.
that they just go around and they take a few patients on the ambulance. They won't put you into a stretcher or anything. You can just walk in. It's not like what the ambulance that we are imagining.
I'll give you some details.
Yes.
Okay.
Yeah.
Thank you.
No worries. It's like a van, I would say.
Yeah.
So we'll
Yeah.
just get the details of that after.
I'll give it to you. Yeah.
Super, good.
Yeah. And before the treatment starts, we would normally bring you into hospital for a special scan. So this is what we call a radiotherapy planning scan.
Mm-hmm.
It's just like a CT scan, but the scan is for us, a doctor and a consultant, to do your radiotherapy planning to your brain. So we can deliver the safe dose to your brain and treat the right area.
Mm-hmm.
That's another appointment before the 33 treatment. During that appointment, we will do a CT scan and we will fit you into a special mask. It's just like a plastic mesh mask fixed on your face, so that it keeps you lying still while you're having treatment, to just make sure we treat the right target during the whole 6 weeks time. Yep. It's quite a tight fitting mask, but you can breathe through the mask. It's just like a net. Yeah. So you will need a mask, and we will also repeat the MRI scan. That's for radiotherapy treatment as well. So you will need this appointment before your actual treatment. So as I say, the aim of radiotherapy treatment is actually to control the tumor, prevent it from growing. What we try to do is control it as long as possible. So it's not 100% that after you receive the radiotherapy treatment that the tumor wouldn't grow again in the future. But we try our best to just control it as long as possible. And again, it would then improve your survival in the future. But there are certain side effects from radiotherapy treatment. I will explain to you basically every side effect that is possible, but just bear in mind some are more common than the others, and you might not get any of them sometimes. So when we mention about side effects from radiotherapy treatment, we normally divide into side effects which we call early side effects, which you will anticipate during the radiotherapy treatment and a few weeks after the treatment, but it will probably resolve after a month from your treatment. But there are certain side effects which will happen a few months or years after your last treatment, which we call it a long-term side effects. So the early side effects are more common. So what you anticipate during the treatment is probably you get more tired than usual. Sometimes you feel slightly sick, or headaches or dizziness, and if you have like problem with work findings like now, these symptoms will probably get slightly worse during the treatment, but eventually it will resolve once you complete your treatment.
Mm-hmm.
And also you will face some skin changes on your skin probably over your left side and probably somewhere in the middle here.
Mm-hmm.
So what you will see is probably skin dryness and sometimes redness and hair loss as well. Hair loss it could be long term, and it's usually quite patchy, so it's not like whole head, but it's just
It's like his beard then.
only that.
I don't need that. I don't need that microaggression. I'm not wearing this mask because of COVID, it's just to hide the beard.
Okay, yeah.
Can't be that bad.
Good. So if your tumor is on the left side, it's probably the left side. Okay.
Mm-hmm.
Yep. And very rarely you'll find change in your taste buds. Like when you eat something, you might find this taste altered a little bit. But all this will eventually resolve a few weeks after the treatment. And also, some people find that they just need more rest during the day while they're having treatment. Probably you just need a nap in between the days if you don't used to do that. Yeah.
Mm-hmm. Just with the taste buds, does that mean that is it all negative, or is it that some things I will prefer and then some things I'll
I think
dislike?
unfortunately, I would say it's a negative,
It's okay.
but it's temporary.
Mm-hmm.
Yeah, but it's the possibility is very low.
Okay.
And I mentioned about long-term side effects from radiotherapy treatment, and you only see it probably a few months or even years after your last radiotherapy treatment. That's because of scarring tissue in your brain and the organs which is surrounding the area.
Mm-hmm.
So there are a few things I need to mention to you. First is cataract formation in your left eye. But again, cataract is something reversible, like you can just do a surgery and can get rid of that.
Mm-hmm.
Sometimes this radiotherapy treatment do impact on your the nerve on your eye and the ear as well. So there's possibility of you having a hearing problem in the future on your left side and some visual problem on your left side. But we would try to minimize all this impact on while we are doing the radiotherapy planning.
Mm-hmm.
And the possibility is again quite low. Some people do get hormone production disturbance in the future because we have our hormone gland sits just at the center of the brain. So if you get hormone disturbance in the future, then we will give you some medication as a replacement.
Mm-hmm.
Again, it's not I wouldn't say it's serious side effects, but it's all like we can compensate it with certain medication or even some injection for that.
Okay.
And some people do face some cognitive problem after radiotherapy treatment. What you would expect is speech problem, probably some memories problem, and if you were to learn new things in the future, you might find it more difficult because your tumor is located in the left side and is quite center in the brain, so there's a possibility that you'll get certain extent of cognitive impairment in the future. But again, it's not 100%.
Mm-hmm.
Yeah.
Does that mean it's better to try and learn new things or not?
It depends on whether you need to learn that. But
In
it
terms
just
of
means
brain.
that you might need more time if you need to learn something. You
Yeah.
might need to take longer than usual because of the cognitive problem. Yeah, but it doesn't mean that you can't learn anything in the future.
So try and work on the piano now rather than...
Yeah, good idea.
Okay, right on. Will do, doctor.
And after radiotherapy treatment, because there will be some disruption to your the blood vessels in the brain, in the future you might have slightly higher risk of getting a stroke. But it's not, I'm not saying like 10% or more than 10%. The risk is still low, but higher, slightly higher than
it was
the
previously.
average. Yeah.
With a higher risk of stroke in terms of exercise, should I avoid doing things that like put a lot of blood pressure in the head, like heavy weights? Or certain
I don't
sports?
think it's related. I do not think it's related. It's because sometimes it's just the blood vessels, which is the formations. It will just change the formation of the blood vessels.
Oh, so it's like they become weaker.
It's not related to the pressure. Yeah.
Okay.
Here we also mentioned about certain side effects, which is really rare, like pain in your face, problem with eye movement, balance difficulty. It's all rare, but it's written down here, but I put it as unlikely, so
okay.
Just keep as reference. And for all patients who receive radiotherapy treatment, there's slightly higher risk of them getting a secondary tumor in the future. What I'm talking about is probably in 20 years time, probably you have about 5 or less than 5% risk of getting a second cancer in the future. And it could be a benign cancer or a malignant cancer. So
well, sure, I'm not going to live 20 years anyway, so we don't need to worry about that.
I think you might. You know, because of the radiotherapy treatment and the chemo treatment, there's a risk of infertility in the future. So we would normally recommend patients to get some sperm preservation. Yeah.
Okay.
And maybe Claire can talk to you about that later. Yeah. And during this whole radiotherapy process as well, we will give you additional chemotherapy treatment. So you need to take the chemotherapy every day, with a supply of antibiotic as well during the whole radiotherapy treatment.
So it's going on at the same time as the radio treatment?
Same time.
Yeah.
Same time, but you can take in the morning before you come into the treatment.
Oh, is it something you take yourself?
Just the tablet you can. We will prescribe that for you.
Oh,
just
okay.
like you're taking a. If you have some hypertension, just a normal pill, but it's a chemo pill, so you need that while you're having treatment.
I'll talk to you more about that.
Yeah, and Claire will talk to you about that. And as well as after radiotherapy treatment, we will give you a break for about 4 weeks, and we will repeat a MRI scan to look at the response. If everything is well, then we will continue on with additional chemotherapy treatment after that. Okay. Do you have any questions or?
No, I think you've covered everything at the off the bat.
Yeah, there's a few more questions about like when the radium treatment will be and when it will be. Is that just stuff I'd ask you? Is it?
When the treatment will be?
Yeah. Like.
So usually what we have to do is we have to do a planning scan, and then we have to make the mould, and that's usually done in about the next week or so. Okay, we'll get the appointments for those hopefully today, if Claire can book them.
Yeah.
And we'll be able to give you those appointments to go away with. And then once the planning process takes place, it's usually about 2 weeks or so before we start the actual treatment, 2 to 3 weeks. Okay, so Once we've got the planning done, we'll be able to tell you when the official dates are to start the treatment.
Mhm.
And then we start every day for Monday to Friday for 6.5 weeks.
So I got 2 weeks to get someone pregnant.
Something like that.
Okay.
Yeah.
Yeah.
How many babies can you make in that time?
Let's see.
That's a bad question.
three a day, 2 weeks. So what's
That's my
that?
power right there.
So
28.
we get that the initial appointment. We get that today.
We'll hopefully be able to give you at least 1 or 2 appointments.
Just
for
the
the
radiotherapy
radio
scanning
scan.
appointment
Yeah.
today.
Okay, great.
And it wouldn't be long until your treatment starts. Yeah.
So then after he goes in for the initial scan, then we get the dates for the rest.
Yes.
You're
right.
Yeah.
You're right.
And it's usually within about 3 weeks of appointment. Yeah. We try to make it about a month after the surgery. So that's usually the time frame. Give you enough time to recover.
Mhm.
Yeah, great.
Do you have any other questions from your side? Or
No,
you
I think
okay?
No, nothing that comes to mind.
No. So we're just hanging around now to get the.
Yes, I just
Or are
need
you going to email them or something?
So I think the doctor just wants to get a consent form agreement with you if you want to proceed with the treatment.
I think so.
Yeah, so then we need to get you to sign that, and then I'll just go through a few things
Yes.
with you as well.
and probably I'll get one of my consultants to come in and just introduce themselves to you. And we need to get your blood test today.
Sorry.
And normally we will bring the patient back again in 1 week time.
Yep.
And just to catch up with you, and if you have any questions, you can always just list out your questions this week, and we can discuss about that when you come back again on next Tuesday. And can you print your name? And we can tell you more about your chemo next week. Yeah, there's a lot of information to take today, so we will do it slowly. Yep.
So there's another meeting this time next week, is it?
Next week, yeah.
Is this more that need to? No.
No, that's it. I'll pass you a copy. So, and then you wanted to arrange for your parents to come over during your treatment.
Yeah, my Mal will probably want to come over this day next week.
Next week, okay.
I think so. I'll check with her first.
Okay, no problem. So I just want to have a look at your wound.
Yep.
Good. Looks good. Any discharges?
No.
Good. So I'll just quickly go out and get a date for the planning scan, and I'll come back in with one of my consultants later. Alright, see you later.
Thanks very much.
Lovely, thank you.
Thank you.
Okay, so, right, let me introduce myself properly. So I'm Claire, okay? I'm the neuro-oncology nurse specialist,
Mhm.
all right? Or otherwise known as a key worker, okay? So you've got myself and Alison Corbett, okay? We work as a team, there's 2 of us. And we cover the whole of the neuro-oncology service, okay? So I'm just going to come and sit over here with you. My legs are a bit short. Lovely. So we're here to be your primary contact, really. So any questions, concerns, any problems, you can call or email us, and we're available Monday to Friday. And out of hours, I'll give you an out of hours number as well, so that you've always got someone on hand to talk to you if you need to. Okay? You feeling all right at this point? It's a bit information overload. What's happened in the last couple of
It's
weeks?
like the sadness of the situation hasn't really come to reality with me yet.
Okay, yeah. Feel like it's still sinking in a little bit.
Well, I mean, I've known about it for like nearly a year now and it still hasn't hit home.
Okay.
It's probably because I'm not affected by it in any way. So the brain surgery, my ability to speak, that was terrible for maybe 5 or 6 days, and then once the swelling went down, things improved quite dramatically. So.
Okay. And you say you've known about it for a year. Is that because you were diagnosed with a low grade, and then what happened? How have you known about it for a year?
Well, I googled it.
Right. Okay. So is it just because you were having symptoms this time last year and you just knew something wasn't right? What was the process?
Of how I sort of deduced that this would be a thing. I don't know, I just sort of had a feeling.
Okay.
I know that is sort of superstitious, but I don't know, I just thought that it was going to be like that.
Yeah, okay.
And in a way I sort of regret not making up that I had symptoms, because they took so long till the second visitation in the hospital. It was like 6 months between when it was first seen and then when it was seen a second time.
Right.
Partly because of the COVID, but more so because the GP was just really disorganized and just didn't get it
Right.
sent over,
Okay.
because they thought, oh well, it's your tumor is benign and you're asymptomatic, so we're not too pressed about
Okay.
getting you seen. And I felt rather differently.
Okay. So this happened sort of around Christmas time, was it? That you?
No, the tumor was discovered in September.
September last year.
Yeah, September, October, I can't remember which one.
Okay. And they said it was benign.
Yep. Which I couldn't figure out how they would know, seeing as how they'd only have one image of it.
Yeah, okay. And then you referred to Mr. Jones.
Yep.
And he did a scan and had a look and said, it's probably benign, we're going to leave
No. When Tim saw it, he saw that it was increasing in size, and so he was saying, okay, this is definitely not benign, we need to
We need to do something about this.
operate on it straight away.
Okay, and then that was when you had your operation.
Yes.
Okay, and what was the date of the operation?
The 13th of July.
Okay. Alright, good. Okay. Good. Excellent. So, okay. So the next steps, obviously Dr. Kai was just explaining them to you there. Okay, so it's 6 weeks radiotherapy.
Mm-hmm.
Now, she mentioned about the grade 3, grade 4 difference. Okay. So the grade 3, if it comes back as a grade 3, we have to wait for a pathology result. Okay. Yep. Then the treatment is still radiotherapy, still 6 weeks of radiotherapy. Okay. Just slightly different chemotherapy.
Mm-hmm.
All right. If it's a grade 4, then the chemotherapy is taken alongside the radiotherapy at the same time. Okay. And it's in the form of a tablet.
Mm-hmm.
All right. And we'll go into a bit more detail about that next week, because on week 1 it's information overload, okay? But basically it's a few tablets that you take before you go to bed in the evening. You sleep through the night, wake up, you crack on with the day, okay? So it's a relatively painless chemotherapy, yeah? So most people get through it very well, they tolerate it very well. There's no intravenous or anything like that, okay, nothing in the veins, okay. If it's a grade 3, then we may have a different alternative chemotherapy, which we know works better with a grade 3 tumour, which does involve an intravenous chemotherapy, okay, just the one.
So that'd be worse at the time, but better in the long run?
Yes.
Yeah.
Yeah. Okay.
Yeah.
Good, okay. I've had a letter from your mum this morning. Is it Jacinta?
Yep. She is,
yeah. And she just said that she wanted to be your primary contact. Is that something that you agree to?
Yeah, that's fine.
Yeah, okay. So have we got her down as your next of kin?
Yes, yeah.
Have you updated a registration form today?
Yeah. I was going to put Jack, but then I realised that it was more sensible to do it with my mum, because she's already organising quite a lot of things that are associated with the Macmillan Trust and stuff like that.
Perfect. Okay, that's good. And you're happy for us to converse with her? There's no problems.
Yeah.
Yeah. Excellent. Great. Good.
You
Okay.
can lie to her a bit and say that I'm in a better condition than I am.
Screw around with the ethics of it, it's fine.
Yeah.
He's like I mean, we only tell her.
Don't mention no kids. I don't think she'd be delighted about that information.
Okay. All right.
I'll just adopt someone and say, oh yeah, this is yours. Don't worry about it.
Yours from now on. Okay. All right. What we'll tend to do is at the end of this clinic, the doctors dictate a letter.
Mm-hmm.
Letters then typed up by the medical secretaries, and then we get it out to you in post. And it just covers everything that we've said today, okay? Obviously, if your mum has any questions about that or she wants a copy, she can contact us and we can send her that copy, that's no problem,
Yep.
okay? That's fine. So, going back to the kids thing, is that something that you would like to do? We can refer you to andrology services at Hammersmith.
Oh yeah, the sperm donation, like definitely. If there's a chance that I have a long enough life survival rate, then having children is very important to me.
Great. So I'll make that referral for you, okay? And what we'll do is you'll hear from them probably in the next week or so, and then you go down to Hammersmith Hospital, and you give them a sample, and then they just freeze it. Okay, so that's how it works.
Mm-hmm.
All right, so we'll make that referral for you. If we're going to do that today, I need to do a HIV screen, if that's okay. It's just part of the process that we have to do to make sure before you donate any samples. Is that all right?
Yeah, it's fine.
Okay. And I need to get you a different blood form.
With the HIV for the testing, could you mention that I did a previous medical trial for HIV, and what they were explaining was that I give what's called a false positive, which is the antibodies for defending against HIV. My body produces them, but I don't actually have the disease itself.
Okay. So you sometimes have a false positive result.
I don't think I had a HIV test since the actual medical research, but they mentioned that if I get a HIV test in the future, that it might give what they call a false positive. So they need to go on to the second section of the test, which will then show that it's not actually actual HIV.
Okay, yeah, great, okay. So that was a medical research, was that a trial, something done in?
Yeah, it was in what was called Hammersmith Hospital. It's not in Hammersmith, but it's or was it Hammersmith Hospital? No, it was the one that's in White City, north of White City.
Oh, right.
Okay.
And how long ago was that?
I think it was 2015.
Okay, great, that's fine. What we do is we'll write that on the form, and I'll also write it on the referral form so that they're aware of that situation. That's great, thank you for letting me know, perfect. Okay, good. So I'll just quickly run through some things with you, okay? You get to keep this lovely yellow photo.
Oh, joyous.
Alright, sorry, it's not a better colour. And you've got our contact details in here, okay? And as I say, you can call us or you can email us, okay? So I've got one for you. I'm aware that you might have to get a ferry today, is that right? Yeah, what time is that?
I have to be there about 7.
Okay, and where from? Dover? No.
Holyhead.
Holyhead, okay. Alright, so we probably need to get cracking, yeah? Alright, okay. There's also some information here about some of the multidisciplinary teams. So if I said to you, okay, we're waiting to hear back from a histopathologist, and you say, who are they and what the hell do they do? Okay, it's just some information here about people and what they do and other people of the team that you might meet. Okay? Whereabouts are you based? Where?
Tooting.
Tooting, okay. So, nice and close to St George's.
Yeah.
So there's just some
Handy
information about support groups and support networks, okay? So if your mum's already in contact with Macmillan, that's fantastic. They're a very good resource. But there's other resource groups as well. And we've even got the Maggie's Centre at the back of the hospital here, which is open for anybody during the week, and they're basically, it's like a Grand Designs building, and it's volunteers, and they have free tea and coffee, and you can just go in, there's free Wi-Fi in there, and it's just a nice place to chill and sit if you have to wait around here for a long time. It's not clinical, there's no doctors or nurses over there, it's just the team, Maggie's team, they're a charity.
Good. I hate doctors and nurses.
Yeah, okay, so do I. Okay. Sometimes during radiotherapy, you get a little bit of swelling on the brain, okay? And what we tend to do is we will monitor you every week while you're on radiotherapy. We'll call you once a week, every Monday, to see how you're getting on, okay? And if you say, if I've only got 1 week and you say, Claire, you know what, I've been having these really bad headaches and I feel a bit sick, that's a key sign that you've got some swelling, okay? So what we would do is start you on a steroid, very low dose, about 2 milligrams of dexamethasone, okay? And that just helps to reduce that swelling and prevent some of those symptoms. Sometimes swelling can become very acute and you would have vomiting and you would not be able to open your eyes, okay? That doesn't happen very often. That does happen, you need to let us know straight away. We'll probably send you to A&E for a high dose level of steroids.
So when you say they're unable to open my eyes, is that they physically swell up like a bee sting?
Just
or
that
just
real headache, migraine kind of, you know, the kind of like a really bad hangover, yeah?
Yep.
Okay, if you feel like that, you need to let us know.
How would you get to A&E then?
So we would just say call an ambulance if it was like that.
Okay.
Yeah, if you were vomiting and you were really ill, we would just say call an ambulance. Okay. Hopefully it won't happen. Doesn't happen very often. Okay. So just some information there about steroids, okay, and why we give you steroids and what they can do. Are you diabetic at all?
No.
No. So we'd have to monitor your blood sugars if we did start you on steroids, okay, just because there is a slight chance of increase in elevation of blood sugars, okay. But if you've got a healthy diet, I think you'll be fine.
All right, to be, yeah.
Good. If you start a dose of steroid, what we'll then do is slowly reduce you down, because you can't just stop taking steroids, okay? You have to reduce them down slowly, otherwise you get really bad withdrawal symptoms, okay? So there's just a table there to keep track of what we say. So if I said, okay, you're on 4, let's go down to 3, write it down so you don't forget, okay? Information there about driving, so you know you're not supposed to be driving now.
No.
Just a big no, okay? Transport. So, what you have to do, there's a telephone number that you have to call, okay, when you have your appointment dates for your radiotherapy and your CT planning scan, which we'll give you shortly. If you call the number for the Sutton Transport Inquiries line and just say, I'm a neuro-oncology patient and I need transport to get me to my treatment, okay, they'll pick you up from your house and they'll bring you back after the treatment, okay. It's a free service, but sometimes they go around the long way. And what they tend to say is, be ready about an hour and a half before your appointment time, so they can pick you up.
Yep.
Okay, so if your appointment's at 11 o'clock, be ready for 9:30, they'll come pick you up, have your treatment, and then go home again.
Will the time of the treatment vary from day to day, or will it always be?
It does usually vary day to day.
Okay.
However, when you get your list, you'll get a long list of all the appointment times. You can ask them at reception to change things. So if you know, for example, you've got an important appointment that day and you'd really like to meet it, you can ask the radiotherapy team if they can do a later appointment and see if they can fit you in. They're quite flexible.
Okay.
Okay. Sometimes, but the actual radiotherapy treatment itself is only going to take you about 10-15 minutes. All right. So you come in. The treatment takes about 5 minutes to do, and then they do all the measuring up and then putting the mask on and everything. That takes about another 5-10 minutes, and then you're out. You're done. Okay, so it's nice and quick. All right.
Good, quick headshot.
Yeah, that's it. Okay, and that's for me. You got this booklet.
I think I have that.
Do you want another copy?
In the house. You may as well.
Yeah. This is quite useful. I mean, you know, as a physically fit, active person, you're probably already doing a lot of what this recommends. Good level of activity, exercise where possible, and healthy diet, they're all key things to help with fatigue. Okay?
Yeah.
But we do expect you to be more tired, and you should rest when you can.
Yeah.
Okay? I'm sorry that all the people in this book are old. Okay? Fatigue doesn't just affect elderly people, it also affects a lot of our patients going through treatment. Okay?
Are there any specific dietary things you should or shouldn't do?
No, just obviously avoid refined carbs and sugars where possible. So
Just a general good diet
just
advice.
a good healthy diet, portion control. Yeah, I'm sure you know all about that already. I don't need to tell you about all of that.
Yep.
Okay.
Unless
Unless you want me to tell you about it.
No, I mean there's a million ways to interpret it.
Assume.
There, during the actual chemo and radiotherapy, in terms of exercise, will there be certain things that will have no benefits? Like someone, Tim was explaining to me about how what the radiotherapy does, it stops new cells from growing. So like doing muscular exercises like lifting weights, wouldn't that mean that they would be damaged and then not have the repair effect?
No, so what it's doing is destroying the cells in the brain tumour. Okay, so what happens is we don't do the whole body, okay, it's just pointing X-ray beams, and lots of them, lots of little ones, all at one particular precision point where the tumour is, okay. Sometimes there's an outside radius just around the outside of the tumour that does get affected as well, healthy brain.
And that's
tissue.
just why the hair doesn't grow and whatnot.
That's it, okay. So sometimes, because of the way that the beams exit and enter the head, you do get a small dose of radiotherapy to the healthier brain tissue as well, okay. But the muscles in your body, none of that should be affected, okay, by radiotherapy. So none of the cells in your arms or your legs should be affected by that, okay? And actually, by toning and keeping the muscles strong, you're doing yourself a favour because we're going to be affecting this side of your head, therefore this side of your body is going to be affected, potentially, okay? So the left side controls the right side of your body,
Okay.
alright? The right side of the brain controls the left side of your body, just to confuse you.
Yep. No, I think I was aware that Tim was explaining to me about how it would affect my right hand. So what sort of things is that going to affect? Is that going to affect just like physical strength and dexterity, or will it be like my handwriting will get worse and just anything? Like, not that I can play a piano, but like my ability to play a piano on my right side.
Potentially. I mean, what the radiotherapy will do is it obviously affects that part of the brain. And this part of the brain involves a lot with memory and problem solving. Hello. Yes, please do. Yep, absolutely.
Okay.
We were just talking about exercise during radiotherapy and how to stay well during radiotherapy.
Great. Yeah.
So, no, absolutely.
So, Ian.
Yes.
Hello, I'm Liam Welsh.
Nice to
And
meet you.
you've got your brother with you.
Yeah.
So what's your
Jack.
name? Jack. Great. And now, Ian, I'll just squeeze in here.
Yep.
Been having a chat with Kai, my registrar. My colleague, Mr. Jones at St George's, has been looking after you.
Yep.
And has obviously told me about you and has done the surgery for you. I was just looking at your scans. And you've had a very good operation with Mr. Jones. We've had some communication from your mum as well, and your dad, and I think your parents are coming over, aren't they? Can I just check with you, and you're happy for us to be talking with your mum and dad about things?
Yeah.
Is that fine? Because I think they're obviously naturally concerned about you, and
Yeah, just a smidge.
yeah, but they were very keen for us to be talking to them about your condition and informing them about things, but obviously we need your, because you know,
Yeah, by all means.
you're a big boy now, you're allowed to say what you
I'd
want.
much rather someone else talk to them about it than me, because they just keep asking the same questions over and over.
So that's fine, Ian. So we'll talk to your parents for you, okay? We're only going to tell them the same as we tell you, okay? We're always going to be honest and straightforward with you. We're never going to conceal anything from you. If there are things that you don't want to know, then you can tell us. And of course, if you want, we can talk about some things with your parents and not with yourself, but only if you say that's what you want.
No, I want the like a brutal honesty rather than anything shielded, because my estimated life timeline is makes a difference. Like if it's 2 years versus 6, that changes a lot of things. So I think it's smarter to know about it, even though it might be depressing.
Yeah, I mean that's the reality, Ian. That information is helpful to you because then you can make some decisions about how you use your time. So, I mean, as we sit here now, we're not exactly sure what that's going to be because the final work on the tumour is still going on. So we have a good idea what type of tumour this is likely to be, but there is still an open question at the minute. So there's two main possibilities, Ian, okay, based on what we've got. Now, neither of these were we expecting particularly based on your scans, because this tumour was picked up incidentally, as I understand.
Yep.
And then we were monitoring it, but it did grow a bit more quickly than we'd expected. You know, just looking at your scans between, you know, October last year and then July, you know, there's a little bit more change. But Mr. Jones seems to have removed all of the tumour that I can see on the scan. I mean, it just does look as though it's pretty much all out. So, you know, all of that.
He's the boss.
Yeah, he is. So then, what has given us cause for concern, Ian, is when we look at the tumour under the microscope, okay? So we had expected something that we would call a low-grade glioma, okay, which can be a very slow-growing tumour. It is still a problem, and it is still incurable, but it's often something that changes slowly. So we found some features under the microscope that suggest this is a higher grade tumour. So this may have been there for a long time, Ian. What happens is that the low-grade tumours eventually do change from low to high grade, and we may have just been picking this up now. You know, so we may have just found this by chance, and if we hadn't found it, what would have happened is that it would have started to make you unwell in the near future, and then it would have come to light. So by chance, it's just been found earlier, and so we found it just as it's on the turn. That's what I suspect. Now, based on what we've got just now, there are two possible diagnoses for you here, okay? One is called anaplastic astrocytoma, and the other one is called glioblastoma, okay? So the anaplastic astrocytoma, that's what we call a grade 3 tumour. So that has a better prognosis generally. And you may have that is perfectly possible. That would fit with everything that we know, but we haven't been able to prove that for sure yet.
Yeah.
Okay? The other possibility is glioblastoma, which is a grade 4 tumour. So this is the worst type. And we don't know that you have that. We haven't got definite evidence of that. If you did have that, Ian, then that is, you know, the kind of tumour that can arise, you know, when these tumours go bad, and it can behave more aggressively. Now, as I say, we don't have definite evidence of that. We have a concern, but we don't know for sure. Now, either way, the treatment you need is essentially the same. It's the same radiotherapy and the same drugs, but it is the prognosis that differs. The treatment can work against both types of tumour, but sometimes the treatment doesn't work here. And sometimes these tumours do give trouble, again, despite the surgery and the radiotherapy and the chemo within a year of the treatment. So we don't know how it's going to be for you. Now, if you do have the lower grade, the grade 3 tumour, then the outlook is much better, okay? Because the treatment sometimes works better and is more durable, and the tumour just behaves, you know, less aggressively. So we don't know at the minute, but the important thing is that we get on with your treatment, because we know that either way we need to give you this treatment, because otherwise the tumour's just going to regrow. And we're going to be back where we started. So we want you to get the best out of the operation that you've had, because we know that that's really important. To have got all the tumour out gives you the best chance. Because we're not asking as much of the radiotherapy and the chemo. You know, we're not asking them to deal with the whole tumour, because that's mostly out. What's left is just whatever remnant that there always is after this surgery, because the surgeons, even when on the scan it looks like it's all gone, we know from decades of experience that there's always some left.
Yeah, Tim was explaining about how all of my brain could actually be affected by the tumor currently, but it's at such a low volume that it doesn't actually get detected by an MRI scan. So
that is exactly right, Ian. I mean, that is a perfect way of putting it, and that's why we use the radiotherapy and the chemo, because the radiotherapy is going to focus on where you've had the surgery, but the chemo goes everywhere. So it treats everything regardless of where it is or whether we can see it or can't see it. Okay, so the two together is a good combination, but to get any benefit, the treatment has to work against the tumour. It has to be sensitive to the radiation and the chemo, and we don't know if it will be or not. There's no test we've got that we can tell us the answer to that. We just have to try and see.
what is the test to see if it has affected the tumours?
Well, we can't test to tell if the chemo is going to work for you or the radiotherapy is going to work. We just have to try it and see it. The test to see if it's worked is how you are, and obviously we do scans over time. So
it's just going to the MRI and see if it's growing again.
We always focus on how you are, though, Ian, because the key for this treatment is to keep you well. So, one of the most important things is how are you? Now, if you're well, then we'll scan you periodically, okay, to look for any bother. Now, if you have a symptom or there's a problem, then we'll scan you, of course, in reaction to that. But as a rule, we're going to do a scan to plan for your radiotherapy, and that's probably going to look quite similar to the scan you've just had following your surgery. We'll then do a scan about 4 weeks after the end of your radiotherapy, see what things look like then. That may not look very much different to the scan we did before your treatment. That's what we would hope and expect. We'll then carry on with the chemo that we'll talk to you more about next week on a monthly basis. We'll scan you periodically, usually every 2 or 3 months during that treatment, to see how things are going.
Okay.
So, because we do scan you quite frequently, we will often pick up a problem on a scan sometimes before you have any symptoms, but we'll just have to see, okay? A lot will depend on just how successful this treatment is for you, in which we can't predict. Okay? We just have to try and see how it goes. So, we're going to get the wheels in motion for this radiotherapy treatment for you. We'll ask you to come back next week, and then what we'll do is we'll talk about the chemo with you next week, because otherwise it's just a bit overwhelming. So we'll focus on the chemo next week. We probably won't have the final result back from the lab next week, but if we do, obviously we'll talk about that. So we may need you to come back again a week after that, because it may not be until then that we've got the final result, and obviously we'll want to discuss that with you face to face. So bear with us, but what we're not going to do is delay your treatment. We're just going to put the wheels in motion, because we know we've got enough information to tell us what to do, okay? And we don't want to give this tumour a chance to grow back. So we've got a plan, Ian. Are there any questions you want to ask me about what I've said?
No, not at the moment.
So, okay.
Oh, actually, with the chemotherapy, when you were saying about how it affects all of the body, just when we were talking to Claire about how it affects exercises, does that mean during chemotherapy that, say, lifting weights, for example, would be a bad idea because it would damage the muscle and they wouldn't have the ability to repair?
You should be okay, Ian, because I know you're a sportsman and a sports instructor, so we want you to carry on exercising, and actually exercise is one of the best ways of minimising the side effects of the treatment. But let's say, when you're on the monthly chemo, you'll have 5 days on and then 23 days off. It's probably more sensible to give yourself an easy week when you're on the chemo and then do more exercise than the 3 weeks off. Now, during your 6 weeks of radiotherapy, or 6.5 weeks, the side effects will build up gradually. So what I would say is during that time, Ian, do exercise, but go easy, okay? I mean, cut it right down. So you're exercising regularly, even daily, that's fine, but just really bring it down, okay? So your intensity is much lower, because otherwise you'll just exhaust yourself, okay? So it's better to do like a little bit of exercise 2 or 3 times in the day, but keep it light. That will give you more in return and help preserve your fitness, which you will then recover. But that 6.5 weeks is going to be the toughest part. Okay. The monthly treatment after, you'll be able to get into a routine and get back to much closer to normal. But you may just have to have once a month, have a light week, and then pick it up again the 3 weeks after. Okay, just you'll get into a rhythm, and you'll know when you're going to be more tired and when you've got more energy and more reserve to exercise harder.
Gotcha.
Okay, so I want you to continue, but you will need to be realistic about your goals and expectations. Okay, and don't overdo it, because there's no prizes for that. You'll just feel bad.
Shit.
Yeah. So you want to get the best out of that. So your fitness stands you in very good stead. Okay, you're only going to benefit from being young, fit, and healthy and strong. Okay, that's always makes every medical treatment easier to manage as a rule. So you just want to hang on to that. But you will lose some ground just because of the impact of the treatment, but you'll recover that in due course. So don't panic about that. Okay, just focus on getting through the treatment. That's a priority, but do keep exercising. But as I say, just keep it light.
Any particular sort of, like, in terms of survival rate, is there certain types of exercise that are better looked at, such as, like, let's say if I focused a lot on marathon running, would that be better than, I know this is very unique sort of information, or say like if I focused on strength training or bodybuilding, is there certain things that are slightly more likely
I think
to help out?
Any kind of cardiovascular exercise is going to be good for you. I mean, marathon running is quite a stress on your body, so that's pushing it quite hard. You kind of
Well, say like park runs or
park runs fine. So I mean, I think all of these things, you can push them quite hard. So what you want to do is do probably a range of different exercises. I think you can stick with the weights, that's good. You can stick with running as well, and any other forms of exercise that you enjoy doing. I think focus on enjoyment, focus on maintaining your fitness. You're not going to be doing personal bests, and you don't want to be depleting your reserves, because obviously if you push the exercise hard, you're going to be depleted. You're going to exhaust yourself potentially, and you don't want to do that in these circumstances just now, Ian. Okay, so you want to leave some in reserve, leave something in the tank for your treatment, but keep up with the exercise and maintain your fitness.
No, I didn't mean during the actual radiotherapy or the chemotherapy. I meant just like in terms of, is there any like research done to how much it would affect the tumours?
Well, I think we don't have good data on that specific question, but there are general data that show that people who exercise regularly and do cardiovascular workouts do better. Yeah. So we know that as a general rule. It's like, good diet, we see better outcomes, but it's a very it's quite a small effect, it doesn't, it's not enough on its own, but it will only do you good. So I think the form of exercise is less important than the exercise itself. Okay.
In terms of, do you know what jiu-jitsu is?
I know of it. It's not something I've ever partaken.
Yeah, it's like a form of judo or wrestling. It's just mostly done on the ground.
Yeah.
Is that dangerous to do with a tumor, or?
I think as things, for now you've just had the operation. We just need to let that heal up.
Oh yeah, I wouldn't be doing anything particularly soon, but.
I think in the fullness of time, I can't see any reason why not. Now, obviously, we'll be scanning you, Ian. So I think for now, I'd go easy on any contact sports. But later, I don't see why not. We've got some patients who do kickboxing and things, and they've gone back to that, and that's been okay. So it can be perfectly compatible with the condition that you have. We'll just have to be guided by how things are, what your scans are like, and so I would say a definite maybe to that, but we're maybe looking a few months down the line.
Yeah. I wasn't expecting it anytime soon. I was just sort of, once the skull healed up, I was hoping that when I have energy levels that are okay, I could get back to it.
I think if things are going well as we hope, then there's no reason why that shouldn't be possible.
Sure, with COVID, it's probably not going to open up within months anyway.
Well, that's the other wild card here, isn't it? We just don't know what's going to happen with that, you know. It's not really under our control, is it?
No.
So we'll just have to keep an open mind, but I would be, you know, wanting you to be doing as much of your normal things as possible, because, you know, our goal in looking after you, Ian, is to keep you well so you can live your life, you know. We don't want to take over completely. I mean, it's going to dominate things for a little while, but in time, I would want you to be getting the benefit by living your life, you know. So that you will have to accept some compromises, but hopefully, you know, not so many that it's, you know, taking away from what you've got.
Yeah. So Tim was explaining to me about how the way that these treatments are, the sort of plan for these treatments is to give a shorter life expectancy as to what certain treatments could do, but shorter life expectancy with a high level of quality. So having the same abilities to exercise or do whatever. But let's say, for example, I have 5 years of life. How much time is, like, towards the end of my life, how much of that time is, you know, me being in a bed in bits, like not being able to do anything? Are we talking a year, or is it just completely all up in the air with a little information?
It is a little bit up in the air, Ian, but, you know, that time when people are poorly is often quite short, you know. I mean, sometimes it does go on for a few months, but it's normally relatively short. And we'll know when we're heading in that direction, you know. I mean, that's looking, I hope, a long way down the line. But
So it's more like a plane gets shot down where I'm fine, and then terrible. Right.
so that's often what it's like.
Well, I prefer that, to be honest. So
That sounds better.
yeah,
Like the 6 years.
I don't want to be
Also-
deteriorating and wearing away. I'd rather have it like, you know, okay, this is it, we're going out.
I mean, often that's what we achieve by treating you, Ian. It's not that the treatment can cure you.
Yeah,
It can
yeah.
achieve that kind of trajectory so that you're not then faced with a situation that just, you know, gradually erodes your health. It's more like when we lose control, it tends to just go quickly, and there's often then nothing we can do about it. But you know, we're not in that situation now, but that is often how it is, yeah.
Yeah, that's still good. I'd much rather have a bullet to the head than, you know, 10 to the chest.
Yeah, I think it's more like what it is. Yeah. But we'll see. So hopefully we'll keep all the bullets away from you just for the time being. Okay.
That one gone away.
Okay. You don't have to think of every question right now, Ian. I mean, that's one of the other reasons we ask you to come back next week. It can be a bit difficult to think of everything you might want to ask right here and now. So if there are things over this next week, just jot them down and we'll talk about them in due course. But unless there was anything else right now, I'll leave you with Claire and Kai, and we'll get the wheels in motion. We'll have some dates and times for your radiotherapy planning procedures before you leave today, and then we'll pick things up again next week. Okay? Yeah.
Yeah, no questions from me.
All right. Well, we'll push on and we'll talk some more. All right. And I'll chat to your parents as well. They've sent us some emails, so I'll maybe email them back tomorrow or something like that, just to put them in the picture. They're not over here yet, are they? Or
No, my mum was over here on Wednesday or Thursday. I think she went home. I can't remember which day it was. And yeah, I think my dad wants to come over to visit sometime after that.
so, but you're happy if I email them? Cause
Oh yeah, definitely.
Just help allay some of their concerns. And, yeah, all right. Well, we'll do that. Okay. Good man.
They'll be asking you more questions than I will.
I'm sure. So we'll deal with that. It's what we're here.
Thanks very much, Liam.
Okay. Bye for now.
See you now.
So we've got the appointment for your scans. you need to be here at about 3:15.
Okay, Thursday, 3:30.
Yeah. Yeah.
I'll be here for 3:15.
Yeah. The scan itself is at 3:30. I will try to get the MRI scanned on the same day, but I couldn't promise you that. But I'll try. Yeah.
So is this Thursday is the planning
Yeah,
scan, or?
that's the planning scan. That's why a CT scan with a mask.
Yeah.
So they'll make the mask as well on the same day. I'll try to get the MRI scan on the same day. If they could do it on Thursday, they'll probably ring you for Thursday. Yep.
No one knew who I was until I wore the mask.
They do some like the cartoon mask for the children. Spider-Man or something like, I don't know. What's
I mean, that would be a large preference if I could get a Spider-Man mask.
Unfortunately, you're 30s. Maybe you can bring the mask back to your house after the treatment and you can draw it.
Yes, make that a large preference, please.
So I'll pass you a copy of the consent that we talked about just now. So briefly explain to you what are the possible side effects. But don't get overwhelmed with that because most of them are unlikely. Yeah. And even as when we say it's common, it's probably about 50%. Yeah. Other than that, it's up to 50%, but it could be just 10%. Yeah.
Gotcha.
So put down the date and time here.
Mm-hmm.
So the radiotherapy planning scan is not in this outpatient clinic.
Yeah.
It's on the same floor, but you just need to go right to the left side when you come into the main entrance and go into the left side and turn right. Maybe you can ask Claire to show you where it is. But there's a signboard which say radiotherapy pre-treatment.
So maybe just get here for 3, or is the that ambulance, will that be arranged to bring him here, or does he need to get here by himself?
So if you need an ambulance, I'll ask Claire to give you a number. You just need to ring them and tell them when you are expected to be here. Thursday, probably you need to ring them by today afternoon,
Right.
after you've gone home. So yeah, they will bring you here, but probably they will drop you down at the main entrance. But you just need to find a way. Yeah.
Mm-hmm.
Good. So Claire wanted to speak to you again, but she's going to grab something for you, I think. So
Spider-Man mask, yeah?
yeah. You can ask them. So I'll just leave you here and she will get back to you later.
Yeah, it's fine.
Nice to see you.
Nice to see you, thank you. That's a little doom and gloom. Difficult to get much crack out of Liam, isn't it?
No, is the answer, right? It's the right answer.
It happened.
Yeah.
Okay, all right. Dr. Welsh, he's a very good consultant.
Mhm.
I've been working with him for a while now, and I think I always trust his honesty. You know, he's very honest with our patients, and I think that's just the best way forward.
Yeah, he didn't strike me as the type to sugarcoat anything.
He won't sugarcoat it. He tries to present these things nicely, but there's only so many ways you can say them. But that's good. Okay, excellent. So
You can ask him to wear a clown suit during it, like Patch Adams style.
I will suggest that to him
Yeah.
and see what he says. Okay, good. Did that answer your questions about the exercise?
Yes.
I know that's
Yes.
where we left the conversation, so you feel like that's been addressed.
Mhm.
Yeah, okay. So back to the pack. In here, there's just some information about, we have a welfare benefits advisor on site. So I know earlier you mentioned universal credit. Is that something that you're currently trying to work through?
Yes. So I have universal credit just from because COVID made me it shut down my job because it was all exercise stuff and that's all been banned.
Yeah.
But it's like sort of up in the air because even if COVID gets cured tomorrow, I still won't be able to get back to work because during radiotherapy and chemotherapy, I might not be able to do a load of my classes, which is going to be difficult for me to say to them because if I say I'm fine now, but I might not be fine in a month,
they're not
and nice as they are, they're not going to
Yeah.
want to have someone who's unable to commit to work.
Sure. Yeah.
So it's all very up in the air.
So I would recommend getting in touch with Patricia.
Mhm.
Okay, she'll be able to advise you what you can claim, and she'll be able to help you fill out the forms. Okay, so she's quite a useful resource. She knows our patients quite well. Her name's Patricia Stanley. She's our benefits welfare advisor.
Mhm.
Okay, if this pathology comes back as a grade 4, then obviously statistics, and I say that with quotations because we know people do live longer,
Mhm.
okay, has this 1 to 2 year prognosis, okay. If that comes back, what we can do is that you're then eligible to claim full benefit through a form called a DS 1500 form. We fill that out as professionals, okay. We send it off to Department of Work and Pensions. They'll get in contact with you and say you have a terminal illness, okay, and
Here's
therefore
£1 million,
you can claim
flight to
maximum
Mexico.
benefit. Exactly, you got it. Okay, so if we do send one of those, would you like us to send one of those off for you if it comes back as a grade 4?
Yeah.
If we do send one off, don't be alarmed by what I write on the form, okay? I have to write those things out so that we can claim, okay? Of course, what we say is that this diagnosis statistically means this prognosis, but we know from other statistics that actually people can live longer.
Mhm.
Okay, so don't be shocked by what you read. Okay, does that sound all right?
Yep.
Unfortunately, if it's a grade 3, the process is a bit more complicated
Mhm.
because life expectancy is statistically longer. We can't fill out that form. Okay,
So I don't get that sweet money.
I know. Okay, but you'll still be able to contact Patricia. She'll still be able to tell you what you're able to claim. Okay.
Let's keep fingers crossed for a grade 4 then.
Well, in some ways, I'm not keeping my fingers crossed for grade 4 for you. But in other ways, things like that do help.
Mhm.
Okay? Good. The other service that we have here at Marsden that we haven't really talked about today, and again, we can talk about this next week if you prefer, is you were saying earlier about the information kind of hasn't sunk in yet and the sadness of the situation. We do have psychological support services here at the Marsden as well.
Mhm.
So if you'd like to speak to a counsellor or if you'd like someone to phone you and give you some counselling via the phone, just have a talk through about the situation, we can organise that for you as well.
Mhm.
Is that something you'd like to do?
At the moment, not really. I kind of feel like to go deep into the thought process of the whole situation is more likely to raise awareness of it, which at the moment I don't think would be a particularly good thing.
That's okay, that's fine. And it might be that actually, 6 months down the line, you say, Claire, I've been through my treatment now, I'm on surveillance, and I would just like to talk to someone about what I've gone through.
Mhm.
And that's okay. All right? Brilliant. We'll stop with the heavy stuff now, okay? I just need you to sign a few things for me,
Mhm.
okay? So the first one is just receipt of the pack. So put this away for you. This way. This paperwork, it kills so many trees. Right. Okay. So that's yours.
Thank you very much.
Okay. That's yours to keep and put all the information in there. And I just need you to sign on this piece of paper to say that I've given you that pack. Okay. Okay, so that's just all that information we've just gone through there, and it just says that you received information from the pack. Sorry, don't worry too much if you.
Number, I'm assuming you guys.
Don't worry, I'll do that for you. Yeah, that's fine.
And then I sign on received by.
Lovely. Perfect, thank you. And then one more, which just says that you consent to the use of email communication. It's one of those data protection things we have to do.
Yep.
Okay. And just confirm your date of birth for me.
It's the 21st of June, 1989.
Lovely, thank you. And have you got time to have bloods today?
Yes.
Yeah. Brilliant. I'll send you around for those. Any other questions?
Someone was explaining to me about how there might be medical research in terms of brain tumours and the specificity of that. Who can I send out information that someone gets consent to sign me on to any of those?
For the clinical trials?
Yes, clinical trials, that was it.
So we run several clinical trials, okay? There's 2 or 3 that are open at the moment. The ones that are open, I would say one of them doesn't apply because it's to people over 60, so that doesn't apply to you. And what it might be is that the other clinical trial wouldn't apply to you at the moment because we've not exhausted all treatment options. Okay, so we run several trials at the moment. There are some new ones up and coming, and what happens is if after treatment the tumour gets bigger or something changes, or then what we do is then look at clinical trial option. Okay, and Dr. Welsh always keeps these in mind with all of our patients anyway. And if something comes up and we think you would be a good criteria to fit the trial, we'll let you know. Okay, we have a whole team of people here. So we've got Ola, who's our research nurse, and we've got a lady called Kathy, who's trials coordinator, and Dr. Welsh is head of the trials for the neuro unit as well. So if a trial comes up and we think you're suitable, we'll present it to you and see what you think. And if you want to sign up to that, then we'll go ahead with that as well.
Okay.
At the moment, the trials that are open do not change your current treatment plan. All right?
Yep.
I'll write down that you're open to clinical trial.
Any money in it?
There's not, I'm afraid.
Oh, waste of time.
Have you done clinical trials for money before?
Yeah, I mean, it's essentially saved my, well, not saved my life, but extended my life significantly, because the medical trial that I did was for, I think, I'm not 100% sure, but it might have been a schizophrenia medication. And so they were saying that they needed people with 100% healthy brains and no issues with that, so that they had to scan that first.
Right.
And strangely enough, the reason that I was in that medical trial was because I lost my job. I got fired for a terrible reason.
Oh no.
So that was actually a positive thing, because otherwise I wouldn't have had enough free time to try this medical trial. So
Gosh.
all very weird sort of silver linings on clouds.
Yeah. Gosh. It's funny how things in life lead you to one thing to another.
Yeah.
It's 28th today. See, now my brain's not working. Okay. Great. Do you know where the blood room is?
No.
No. And have you signed the consent form with Dr. Kai?
For the blood room?
No, for the radiotherapy.
I think so.
Did you sign a form with her?
Yeah.
Yeah?
Yeah?
Yeah.
And did she give you the appointment time for your CT scan?
Yes.
Yes.
Thursday, 3:30, but come at 3:15.
3:15. Lovely. Okay. Good. So these are the forms. All right. So the test that we're going to do today, we'll do a test on your kidney function and your liver function. We also look at potassium, salt, all the electrolytes in the blood. Okay. Then we look at calcium, magnesium, glucose, and then on this form it's red blood cells, white blood cells, platelets, so all of the hematology side of things. And then on this form, so this is the form that we have to do as a virology screen, which includes the HIV test prior to sperm banking. All right. So all you need to do is give the forms across to the phlebotomist, and they should do all this for you. Okay. And hopefully you'll get it all done, and you don't have to be bled more than once.
Good stuff.
All right. That's excellent. Okay. Well, it was lovely to meet you. We'll see you again next week. I'll show you where the blood room is.
You know how long the blood test will take?
Depends on the size of the queue, but usually it's about 15 minutes.
Oh, right.
That's good stuff.
So let's go and have a look. And I'll just give you a slip so you can put into the
It's a very morbid name. I've never heard of like a blood room before.
blood room. It's probably not officially called the blood room. It's probably the phlebotomy room.
Yeah, that sounds a bit more.
If you just wait here a second, I'll just grab the slip for you.
Right out.
Young man.
You doing? Yeah, doing fine.
So how are you?
Yeah, no complaints.
Excellent. How have you been this last week?
Yeah, like unnoticeable for the most part. No headaches.
Yeah.
Haven't been sleeping the best, but I reckon that has far more to do with the heat and our road. If you leave the windows open, bang on the clock, there will be enough noise to wake you up at around 8 or 9.
Yeah. So, okay. Any questions for me left over from last week? Anything that was on your mind this last week?
Nothing that was left over, but I think the biggest questions are from my parents. Have been digging around for loads of research, and so they had a lot of questions about some of the medical trials. I think the one that they were focused on the most was one in Duke University, and it was about a treatment that's done before any radiotherapy or chemotherapy, and they were just wondering to like pick your brain about that sort of thing, and if there's connections or advice that you would give about which trials to get into.
Well, I mean, trials in North America are pretty much off the table, unless you go there, and it's not really feasible to go there at the minute. I mean, the coronavirus situation is completely out of control there, so I don't know how badly Duke is affected, but I think Carolina is pretty bad. So as a rule, trials in North America, you're going to have to live in North America. So unless you've got North American health insurance, it's not really going to be feasible. There's a very few institutions in North America where they will have funding for patients from outside the US to receive treatment, but that's not Duke as far as I know. So without North American health insurance, looking at 6 or 7 figure bills. So you need pretty substantial financial resources to take that on. Now, I wouldn't recommend that anyway, because this is experimental treatment, and it may not work for you. So you'd be taking on a lot of risk for not any guaranteed benefit. So I think I said I would have a chat with your parents here, and I've not had a chance to give them a call, so we'll come back to that. But the the treatment that I'm going to recommend for you is at the moment regarded still as the gold standard treatment for what I think your condition is, because we've got the report back now from UCLH. I printed it off to give a copy to you. Now, what we've got back on this, Ian, is that, and this is one of the things we needed. We've demonstrated that you've got what we call an IDH mutation. Okay, so we needed to show that the tumour had this molecular change to be sure that we were dealing with what we call an astrocytoma. Okay, so that was one of the things that we didn't have in the results from St George's. You know, their test had been negative. So what we've done at UCLH, we've done some more thorough testing, what we call DNA sequencing, where we just read out the code. And we found an uncommon mutation. That's why we didn't pick it up at St George's. That's what we were expecting to find. So that was the most important thing. Okay. Now the other things that we have identified are all sort of somewhat reassuring in terms of your diagnosis, Ian. So you know we've got, I think, on the basis of this information, something that I would call an anaplastic astrocytoma. Okay. Now that's what I thought we were dealing with, realistically.
So does that mean that it's stage 3, or
Well,
is that still not confirmed?
It's not stage. That would be a grade 3.
Oh, grade 3.
Grade 3, yeah. Now on here, it has said that the findings are compatible with a grade 4, but there's actually nothing to support that here. You know, the things that would tell us it was grade 4 are all absent.
So why have they said that it is qualified as a grade 4?
It must just be the way it looks to them, and you know, so I think it doesn't really meet the criteria for grade 4. So I think it's a little bit moot whether this is grade 3 or grade 4. So what I'm going to do, because it has implications for clinical trials further down the line here, I think we're just going to call the tumour an anaplastic astrocytoma. I mean, that's kind of what it looked like. In the end, that distinction, grade 3 or grade 4, is not necessarily that helpful, because it doesn't in the end change the treatment. And you know, there are some situations where the results from all our tests are, you know, kind of on the border of two different classifications, you know, where it's not kind of clearly one or the other. So we're just going to label this as anaplastic astrocytoma. So we're going to treat you on that basis. That's the way we've set up your treatment. So that's this course of radiotherapy with the chemotherapy temozolomide, and then we'll do 12 cycles of the temozolomide afterwards, all being well. Okay. We'll note these results, but in the end, we have to make a decision about your treatment. So we'll you know, call it, as I say, anaplastic astrocytoma, because that's I think most consistent with most of the information. Now, in terms of clinical trials, you know, I mean, there aren't any specific clinical trials that I would recommend for you at this point. And you know, stuff in North America. I mean, North America, because it's much bigger, will always have more clinical trials open, but you know, they're in some difficulty in most of the medical centres there at the moment. So I don't think that's really a very sensible option, but I'll talk to your parents about that for you if you like, because you know, you did mention you were happy for me to do that last week, so we'll do that.
Yeah, they seem to be, I suppose, using what abilities they have to try and be helpful, and theirs is rooting around for other ways of treatment and things that
Well,
could help?
I mean, at the minute, you haven't even had the standard treatment, Ian, so, you know, we want you to have the radiotherapy because we know that's crucial. Drug treatment and other kinds of experimental treatment may have something to offer, but, you know, everybody needs to have the radiotherapy because without that, we're never going to get control. So what we're proposing now is, I think, the treatment that you need to have. Beyond that, we'll see, and it will depend on whether we think you need more treatment, and we'll only know that in time. So I'm going to give you that copy so you can put that with your other sort of records. It's printed double-sided for some reason, so just bear that in mind. It's on both sides. So yeah, so it doesn't kind of, you know, we don't quite meet the criteria for grade 4. So, you know, we're just going to call it grade 3.
But would I be right in thinking that it's towards the end of grade 3 rather than towards the middle or the start?
Well, it's hard to say. I mean, it's hard to say, Ian. I mean, what we can say is it probably was low grade in the past, and now it isn't anymore. And the way that we classify these tumours has been changing over time as we've got more information. So, you know, this is different from the sort of standard grade 4 because you do have this mutation. You know, and I think what you have is a tumour that was low grade and has started to change, and that's when you got your symptoms. You know, and that's consistent with everything that we've seen from your scans and from what's in that report.
Did you say from when I got my symptoms?
Yeah, because you know, this came to light for a reason, didn't it? You know.
No, I went into a medical trial and they gave an MRI and they were able to detect it.
But in retrospect, you know, you've mentioned that things were not quite, you know, were not quite the same. I mean, I think you know, that's right. The scan picked it up, but now that we know it's there from what you were telling me last week, wasn't it the case that you would look back and say, well, maybe things have been changing?
There was like elements of it that, some minor ones to do with my ability to speak quickly that I thought were just me getting a little bit older, but may have been from this, Yeah,
so quite subtle, but you know, in retrospect, that will have been because of the disease. Now, you know, it's good that it got picked up with the scan, because what would have happened otherwise is that we'd have only picked it up when those symptoms were starting to cause more trouble for you, and then of course things may have been more difficult then. So, you know, the scan, we just got lucky, you know, it's just a kind of chance thing that happened, but you know, it was starting to affect you, even though it was relatively subtle and something that, yes, you wouldn't think, oh, I must have a brain tumour because of it. You would just think, you know, it's not what anybody would be thinking about. But then, now that we have your diagnosis, we look back, we can see, well, actually the tumour was starting to change, because this tumour may have been there for like 10 years or 20 years, we don't know. And obviously in the past, it didn't really impinge on you, but as it started to change, then it's kind of manifested, because when they grow more quickly, they disturb the brain a bit more. Yeah, okay. So we're going to call this anaplastic astrocytoma, because I think that's what it is. Now, what we need to talk about today is the chemotherapy component of your treatment. So, you know, the radiotherapy was what we concentrated on last week, but, you know, we're going to give the chemotherapy alongside the radiotherapy. So you're going to have the chemo tablets once a day, every day. Now, your radiotherapy, Ian, is going to be 33 sessions, okay? But you don't have treatment at the weekend, so there's no treatment on the Saturday or Sunday. Okay, so it'll be 6.5 weeks now. But the chemo, you have that every day, 7 days a week, okay? So you
Am I able to take the chemo at home?
Yeah.
Okay.
So it's tablets, and you have the chemo and you take it home. Because what we normally suggest is you take it at night, just before you go to bed. Okay, because that tends to minimise the
Tiredness.
the side effects are less when you do that. The thing to remember is that the chemo is 7 days a week, whereas the radiotherapy is just the 5 days a week, so you continue through the weekend on it. Now, what will happen, Ian, is that you'll have a collection of tablets to take each night. So the dose that you need is based on your body surface area, okay? And that is calculated from your height and weight.
This is the BMI, is it?
Well, not quite, because that's your body mass. This is like your body surface area, so it's a
okay.
little bit related, but it's not quite the same. It's actually not very sensitive to your weight as such. So the dose that you need will almost certainly remain constant all the way through. Okay.
Yep.
So the dose will be made up by, as I say, a little collection of tablets. It's not just one tablet. The number of tablets will depend on the dose, which we'll calculate for you. Okay. So what you'll do is you'll take these tablets at night on an empty stomach with a glass of water, and you'll just do that all the way through. Okay.
Empty stomach at night.
So what we want is you maybe to be at least 2 hours after your evening meal. Okay. Now the reason for that is that the chemo, the absorption of the chemo is interfered with by food. So if you have a full tummy and you took the chemo with food, you would get less of the chemo than we were intending. So nothing bad happens. It's just that you don't get as much of the drug. So we like.
It's pretty bad in my opinion.
Well, I mean, but it doesn't make you unwell, is what I mean.
Yeah.
There's no kind of interaction with food. It's just that you just don't get as much. So we want you to have the chemo either an hour before you eat or 2 hours afterwards. So we normally suggest you take it at night because it does seem to reduce the side effects. Okay.
Okay.
So you can sort of organise things to manage that. Now you will get some anti-sickness medicine as well, because the chemo can make you feel sick. Okay. So what we suggest with the anti-sickness medicine is that you take that in the evening, maybe with your meal. We want that on board at least an hour before the chemo. Okay. So you'll have the anti-sickness on board, and that will mean that you should be okay, because it's very effective, the anti-sickness. And what you'll do is you will take the anti-sickness twice a day, so you'll take it in the evening, at least an hour before the chemo, and then you'll take it again in the morning, and you'll just do that. Now, once you've a week or so into treatment, a lot of people find that maybe they don't need the anti-sickness as much, or maybe even at all, whereas other people do need to carry on with it. It's quite variable, but not everybody needs the anti-sickness all the way through. Okay.
How would they discover that they didn't need the anti-sickness?
You just have a go at skipping it, see what happens.
And I'm assuming there's some side effects to the anti-sickness if they would.
The main side effect of the anti-sickness, as you say, it does have side effects, is constipation.
Okay.
So that is the thing that often bugs people with it. Now, it is somewhat constipating, but it does vary a little bit from person to person. Several ways of dealing with that. One way is just to vary your diet. You can eat more fibre. You can have prunes for breakfast, that kind of thing. So some people like to do it that way. Other people prefer just to take some laxatives. And of course we can give you those, that's no problem. Other people just don't find it's that much of a problem. So it does vary. Now what we say is we don't want you to go more than 2 days between having a motion. Okay? So, if that happens, then we definitely need to do something to get you moving, okay?
So is that like 48 hours from time on the toilet to, okay, I haven't gone to the toilet, so need to take laxatives?
Yeah, that's right. So you can do it kind of naturally, just through dietary measures, or you can take some laxatives, or a bit of both, whatever.
Just with something that you said there, that bring you back to something that might be important. I generally tend to fast a lot, just out of like that's my habit at this stage. I would sometimes have lunch, not all the time, and then normally just have like a very big meal before, or just at the end of the day.
Yeah.
Is that good? Is that bad? Should that be changed?
Well, the only thing I'd say about that, Ian, is that if you have a big meal in the evening, it may take a little while to digest it and go through, so that might take
Up to 3 hours rather than 2. Yeah, I usually use the meal because it puts me to sleep, so that's sort of.
So if you eat like at 8 o'clock and you have a big meal, then it might be quite late before you've actually digested that. So, I mean, you could either eat a bit earlier, so still have a big meal, but just try and bring it forward a little bit if you can.
Mm-hmm.
Or, kind of eat a little bit more at lunchtime and a bit less in the evening or something like that. You might find, with skipping lunch or fasting during the day, you may be fine to carry on with that, or you might just feel a little bit depleted, in the afternoon. You might feel a bit washed out, so you might feel better to have a little bit of something at midday. Might just help manage the treatments, both the chemo and the radiotherapy. I mean, that's something you can sort of see how you go, but I think, with that evening meal, it might just, you want to maybe just eat that a little bit earlier, maybe 7 o'clock or 6 o'clock, I don't know.
Yeah, I'm far closer to Spanish dinner time.
Yeah, so that, and that, I mean, that's okay, but it's just, of course, you don't have to take the chemo at night. It's just the regimen that we tend to find works.
Yeah.
But you don't have to do that. And you could take it in the middle of the day, for example, when you're naturally fasted. It's perfectly doable. We would just want you to have the anti-sickness on board, about an hour before, and then you'd have the other anti-sickness at the end of the day. But that's okay. You can just take it with your meal. So that might work better for you in terms of your natural regimen, and that's okay to do that if you prefer. You don't have to take it at night.
So could taking an antiemetic with a lunch, like a normal size lunch, I don't have a huge lunch, and then 2 hours later when the stomach is empty, take the chemo pill, and then normally, like myself, later on in the evening have my meal. Is that
totally reasonable? Yeah.
Okay. Well, I might try that, and because it's probably easier to not change my habits and see how the chemo works with that, and if it's terrible, then change the habits around.
Yeah. So I think that's perfectly sensible, and it is one of those things you just have to try and see a little bit. But I think that would work and be less disruptive to your routine, wouldn't it? Okay, so I mean, in terms of the side effects, we've touched on a little bit. I mean, the chemo side effects will overlap a little bit with the radiotherapy side effects. You can't always disentangle them and run them together. The chemo will cause a little bit of fatigue, as will the radiotherapy.
So extra fatigue then?
Yeah, I mean, the fatigue with the radiotherapy is definitely more than with the chemo. The chemo can give you some nausea and sickness, as we've talked about. You can get a bit constipated as well. Partly the chemo, partly the anti-sickness. You can get a metallic taste in your mouth with the chemo. It's not a bad taste, and it doesn't seem to affect people's appetite particularly, but you'll notice it's just temporary. Food doesn't seem to taste bad, it's just a bit different. You'll just have that slight metallic taste there. You will maybe have a slightly less good appetite. It might just be that your appetite's a little bit less, or it may be much of a muchness. It's not uncommon for people to lose a little bit of weight just because you are eating a bit less, but it's not usually a big change.
The diet suppression wouldn't be a bad thing for me, to be honest. It's a bit of a problem.
Okay, well, we'll see how you go. The chemo, it very rarely causes diarrhea. That's not very common. It's nearly always the constipation. can affect your liver. You wouldn't know anything about that. It would show up on a blood test though. So we do a blood test once a week to monitor that side of things.
Should I cut out alcohol then?
You don't need to completely, but you will find that you won't want as much. You know, a little bit will go a long way, but you don't have to be teetotal at all. And you can have a little bit of something, but no, your liver, it's not at a level that alcohol's a problem. It's more just the chemo sometimes upsets the liver. It's idiosyncratic. It'll either happen or it doesn't happen. It's, you know, I would say about less than 5% of patients where that's an issue, and we just pick it up on a blood test. Often we can just carry on and ignore it. Similarly, a few people can get a rash. The rash is often just a bit itchy, not very dramatic. It's often easily managed. It can be on your trunk or your arms or your legs. Just occasionally the rash is more of an allergic reaction, and then we might have to stop the chemo if that happened. But often the rash can just be managed and we can carry on. And we've got a good dermatologist here who could help us if we needed it. So that brings us on to the more potentially serious side effects of the chemo, but which are not very common though. But they are the main, you know, serious side effect we have to be vigilant and alert to. So the chemo can affect your immune system. Now it does that by affecting your bone marrow and the blood counts. So all chemo drugs will do this to a degree. So what can happen is that your white cells, which protect you against infection, can fall. The particles in the blood called platelets that protect against bleeding, they can decline as well. Now usually with this drug given in this way, the effect on your bone marrow is fairly minimal. So quite often we don't see any problems at all with the blood counts, but it can happen. Sometimes it's just one, like just the platelets or just the white cells, sometimes it's both, but most often it's neither. Now again, we'll check your blood counts each week during your treatment, and we'll monitor that. So if your blood counts did drop, then of course we might have to stop the treatment. Normally though, the blood counts are not so low for so long that actually there's very much risk. But if you ever felt unwell during the treatment, Ian, you should check your temperature, even if you're not feeling hot or cold, okay? Because you could have a fever. It might not show up in a normal way when you're on the chemo. So you need to have a thermometer at home that you know how to use and which works. And the temperature that we would ask you to call us if you ever found a temperature of this level or above is 38.
Okay.
We'll give you a card with that written down. Now obviously if you feel unwell and your temperature is 37.
38 was what I was guessing would be too high, so I don't think I'll struggle to remember that.
But if you were 37.9 and you felt unwell, you would still call.
Yeah.
You just use your common sense. But certainly 38 or above, you need to call us. Because it could be, and this is rare with this treatment, but it could be that you'd need emergency antibiotics. Okay. Now, if that were the case, it's a nuisance, but it's just a trivial problem that's easily sorted. But if it was left and you didn't call, then the infection, if it was an infection, could get out of hand and could be life-threatening. Because if your immune system's not working properly, it can't defend you properly. So in practice, what tends to happen if there is an infection, it tends to be one from your own body. A bug in the gut gets into the blood, and then the immune system can't deal with it because it's depleted by the chemo. That tends to be what it is, if it happens at all. But that is uncommon.
So I should be quite safe with eating food, avoid takeaways?
I mean, just use your judgment, you know, ones that you know are okay and that you've eaten at before and you've not had problems. So I think, yes, just try and be, you know, but I would hesitate to use a new place that you don't know about, where you're not sure. You know, the risk of infection is low with this, but it's not zero. You know, you just need to be vigilant about that because it's one of the serious risks. So that is something to say, but it is uncommon. Now, the risk of bleeding because of platelets being low is very small as well. Now, that would often show up as a rash on your body before you knew anything about it, often little pinpoint red dots that don't blanch when you touch them. Or it could show up as a nosebleed, or it could show up as blood in your urine or from the back passage. So if you had anything like that, again, you would call us straight away, because you might need a transfusion or a top-up of your platelets if they had dropped low. But it's really unlikely to happen because we'll be monitoring your bloods each week. Just occasionally we do find that the platelets drop with this drug. Some people seem to be sensitive. It's about 1%, I would say, have that problem, and then we just have to stop the drug, and sometimes we're not able to go back to it. So we just have to accept that risk. But the potential benefits in controlling the tumour certainly outweigh those risks.
Yep.
Now, the other thing to say, we do know that there's always a risk of blood clots, or venous thromboembolism is the jargon, with chemo, particularly for patients who have brain tumours. Now, that risk is low. It's probably around 5%, but it's a risk that we need to be aware of. Now, staying hydrated and staying physically active are the best ways of minimising that risk. Okay?
That's good news.
Yeah. So you just need to make sure if you're exercising or it's hot that you don't get dehydrated, rehydrate. Just be, you do that anyway, I'm sure, but
Yeah, I'm pretty good at that.
yeah, so just, be, especially if it gets hot again, just be aware of that. So, because those are risk factors for blood clots. Now, if you've got a blood clot, the way it could show up would be as swelling in an arm or a leg. And you think, well, why is my arm swollen? Why is my leg swollen? Often would be painless, but you just notice it's a bit swollen. So if you get anything like that, again, you call us. If you're not sure, you just call us, okay?
Yep.
Because a blood clot is trivial if it's treated. We'd have to treat you with blood thinning medicine. But it's trivial if it's picked up early. But if it's left, the clot could travel into your heart and can clog up the system and prevent the flow of blood through your heart and lungs. So the problem is not so much just the swelling, that's a trivial thing, as if the clot were to travel.
Yeah, just to be released and then, yeah.
So it's one of those things, don't be paranoid, but just be aware. And if you did have a swelling, you think, why is my leg swollen? Why is my arm swollen? You would call us straight away, okay? Because it's trivial if it's picked up quickly, but it could be life-threatening if it was ignored.
If blood thinning medication is needed, if I saw swelling, would it be smart for me to take an aspirin while I'm calling it? Or?
Probably not an aspirin, Ian, because it's probably not enough, so don't worry about that. These things often change over days rather than kind of minutes. So, as long as you called us promptly, and the message is, we've got an emergency number that works 24/7, you would use that number. So you would call even if it was kind of night time or the weekend, because we can sort things out, and if it's something that needs sorting out then and there, it can be done. Okay, so it's really just to explain. There were certain circumstances where we would want you to contact us without delay, but it's unlikely to happen. But if you're aware and and there is a problem and you know what to do, then we'll keep you safe. Okay, so that's why we tell you these things. Now, the chemo could obviously have an impact on your fertility. It's not going to affect your testosterone levels. It's not going to affect your, your potency, but it could deplete your sperm count and your ability to father a child. So now I can't remember what we decided last week, because we will have brought this up with you. So we do.
Sperm donation definitely.
Yeah. So
Hammersmith Hospital, isn't it?
Yeah. Is that all set up for you now?
No. Is that something that I do by myself? Or?
So the way it works here, we do some blood tests for you, and we do a referral for you to Hammersmith.
Yeah, I remember that's something to do with HIV.
That's right. Yeah. Did we do? I'll check on the computer. We should have done those last week.
I definitely did give blood. I don't know if it was specifically for the HIV test.
I'll check that. We checked that, and we checked some hepatitis tests, viral hepatitis, because that's what the lab need. And then what used to happen is it was like a walk-in service. They had certain opening hours and you could just present yourself at the lab. Nowadays, because of COVID, they probably have timed slots or so. I'll check with my nurse specialist, and it's Alison who's here this week, so we'll get that sorted out. Now, the likelihood of the chemo compromising your fertility is actually fairly low, but it could happen, and it's just unpredictable, Ian. So we want to make sure that you have the sperm banking done before we start. Okay. Really, that's it in terms of the side effects of the chemo. Some of the information we gave you last week did talk about the chemo. I don't know if you've waded through it, or there's a lot in the stuff we gave you, but there is part of the information that is talking about the temozolomide. So pretty much everything I've said is written down in those sheets. So unless there's any questions you want to ask me, we should go through the temozolomide consent form just now.
Yep.
Okay. So I'll talk you through this. It's basically just recording that we've had this conversation. That's you, Ian Ward. That's me, Leanne Welsh. We're talking about treatment for what I've called anaplastic astrocytoma, which is temozolomide that you take by mouth. So you're going to have it daily. So actually, I'll just change that because it's going to be 45 days.
Okay.
So you're going to have 45 days of the treatment during your radiotherapy, and then you're going to have it monthly when you'll take it for 5 days on and 23 days off, and you take it at a different dose for this, but we'll come back to that later.
Okay.
So the reason for giving you this treatment is to improve your survival, control the tumour, and prevent symptoms that the tumour would cause you. We've talked about the side effects. Now, some of these are taken from the product literature, and some of them are not really very realistic. So, but tiredness, constipation, reduced appetite, yes. Headache, not really. Metallic taste, yes. Rash, we do sometimes see that. It doesn't cause seizures, nor does it.
It says the metallic taste happens 1 in 100. That sounds rare.
Yeah, it's pretty much universal. So these are the frequencies taken from the product literature that's in the box of chemo that you'll get, but they're just ridiculous. These are what were reported in studies, but pretty much everybody gets that. Pretty much nobody gets that.
No one gets the hair loss.
You don't get hair loss with the chemo, no. You get hair loss with radiotherapy.
Oh yeah. Thought I got lucky there.
No, but your hair will regrow while you're still on the temozolomide afterwards. You know, so the chemo does not cause hair loss.
Yeah, I think Tim was saying that it will grow back, but it'll grow back a little bit thinner. But he was saying because I've got thick hair, it might not be too bad.
Sometimes it grows back pretty much the same as it did. And some people don't get as much hair loss with the radiotherapy as others, so it does vary. We can't really predict how it will be, Ian. Allergic reactions are uncommon, diarrhea is uncommon, okay? So the ones I expect, you're going to get some tiredness, you're going to get reduced appetite, constipation, you're going to get a bit of metallic taste, you're going to get the hair loss because of the radiotherapy, and that's about it for that lot. The serious side effects we talked about, infection, that certainly is less than 5%. Blood product support, which would be a platelet transfusion, and that is very rare. Liver injury, yes. I mean, you know, it's about 1 or 2% where it's actually something of any significance. Talks about the fertility. Obviously, you shouldn't father a child while you're on the chemo. Blood clots we've talked about. So, Ian, there's a bit.
Not that I would be, but just out of curiosity, why wouldn't you attempt to father a child while on chemo?
The sperm are abnormal.
Oh, okay.
So even if your sperm count's not affected, the sperm...
It's damaged in some...
Yeah, so you know, there'd be a much higher chance of having a kind of abnormal pregnancy. So that's why we say that. And that risk persists for about a year after you finish the chemo, okay? Bit for me to sign, which I've done there. And then the bit for you to sign is here. We just need you to sign, print and date there. Now, what we'll do, on the first day of treatment, Ian, we're going to go through all the medication with you. So we're going to give you the medication. We'll give you the chemo, the anti-sickness, and we'll go through it with you on the first day. There is another set of tablets that you'll get given on that first day, which is some antibiotics. These are preventative antibiotics. They're probably OTT, but they're part of the standard treatment that we have to give you. So these protect against a kind of pneumonia that is a theoretical possibility when you're on the chemo every day. It's called PCP, the pneumonia. It's amazingly rare. I have never seen it in practice. The chemo tablets potentially can make you more vulnerable to this, but it's in practice something we just don't see. Anyway, you'll have the prophylactic antibiotics just when you're on the radiotherapy. You take them Monday, Wednesday and Friday, okay? We'll go through them with you on the day. It's just some extra tablets to take. They're just a bit of a nuisance, but we have to give them to you, otherwise we'd be negligent. But I suspect they do nothing. They're just part of the treatment that's got embedded, and we have to give them to you. But really, I think they're by the by. So we'll give you
Have it more than actual something with meaning.
Yeah, it's because they were used in the clinical trials, and so, you know, if we don't give them to you, we're negligent, but we know in reality they're probably not contributing anything useful. There must be probably one patient now and again who gets any benefit from it. Nearly everybody, it's just a waste of time, but that's just how it was stuck with it. So you'll get those, you'll get the anti-sickness meds and you'll get the chemo tablets themselves, okay? But we'll go through them with you on the first day, show you what they are, and just make sure that you're clear what you're doing, okay? Now, are there any other questions that you want to ask me?
Nothing that is, you know, burning.
So you're happy for me to contact your parents? Probably the best thing is if I phone them and just have a chat. I'm in clinics all day, kind of every day pretty much, except Friday afternoon, so I might try and catch up with them on a Friday afternoon if that's all right. I can't promise it'll be this week, but I will talk to your parents for you, and we'll go through some of the questions that I'm sure they'll have. And then, of course, if you have any more questions yourself...
Expect far more questions from them than from me.
I know, that's all right, I understand. If you have any more questions though, you just get in touch with us, you can just contact us, but otherwise we're basically ready to go. We're just getting on with designing your radiotherapy treatment now, and then we'll see you on the first day of treatment.
Yep.
I'll just check the blood test results, I'll scan this in and give you a copy of this, and we'll just check that we're set up for Hannah Smith, okay? Alright.
Set up for Hannah Smith, did you say?
The andrology, the sperm banking.
Oh, I went to school with a girl with the same name. Completely unrelated.
Well, let me just check. Alright, very good.
Thanks, Liam.